which is her presentation, in addition to having taken on to give us an introduction to survivorship. And I just want to say how grateful we are that you agreed to do both. My friend and colleague, Dr. Keating.
Great, thank you. So it's a pleasure being here again. This one is So I am a physician. I'm actually a general internist for a primary care physician in Boston, and I'm also a health services researcher who studies the delivery of cancer care, quality of cancer care across the cancer care spectrum, and have done a bit of work on cancer survivorship care, although actually today I'll be presenting primarily not work that I've done, but work that others have done, thinking about the delivery of survivorship care. So as an overview, first I'm going to just briefly touch on specialist versus primary care-centered models of survivorship care. We'll talk a little bit about physician views about providing survivorship care, and then a little bit about engaging health promoters and community health workers in Mexico with some work that I've done with some of the people here today to think about how those populations could be engaged to deliver survivorship care in the future. So, as I alluded to in Julia's talk, breast cancer survivorship care has several goals. Number one, to detect recurrent and new primary breast cancers. Number two, to identify and address and treat late effects of treatment of breast cancer. And then, importantly, to provide psychosocial support to patients and their families. In the US and Canada, as well as parts of much of Western Europe, typically guidelines for survivorship care recommend routine visits with a physical exam and history on intervals that start off every 3 to 6 months and then become closer to every year after several years, as well as annual surveillance mammograms and additional testing only if symptoms prompt someone to be concerned about a recurrence that you might want to look for. So who should care for cancer survivors? Cancer specialists, generalist physicians, others? I'm going to come back to this question at the end, but I will tell you that the question of what types of models of care can provide care for cancer survivors has been addressed quite well in Canada and Britain by a researcher named Eva Grunfeld, who's currently at the University of Toronto. And she's done a couple of randomized controlled trials trying to assess delivery of survivorship care. And these, I'm going to present to you some results from her largest study, which was published in 2006 in the Journal of Clinical Oncology. She led a multi-center randomized controlled trial in Canada, where she took 968 women with early-stage breast cancer who had completed their adjuvant treatment and were about a year out from their diagnosis, and randomized them to receive follow-up care from cancer center physicians or from family physicians, with consultation with specialist physicians when necessary. The generalist physicians were given some follow-up recommendations. It was a single-page list of information that went over information about how often they should encourage patients to come in for a physical exam and a medical history, how often they should have mammograms, which was annually, the fact that they do not need routine laboratory and radiologic tests unless symptoms suggest, and for women on tamoxifen who still had a uterus, that annual pelvic exams would be indicated. The study outcomes included serious clinical events because the biggest fear that people have had about the idea of specialist physicians not leading the survivorship care of these patients is that patients would develop serious problems that might be missed, such as cord compression from a metastatic tumor pressing on the spinal cord, or pathologic fractures causing lots of symptoms, hypercalcemia, uncontrolled local recurrence, brachial plexopathy, or poor functional status. They also collected information on recurrence, death, and health-related quality of life, anxiety, and depression. And what did they find? Well, quite good news, in fact, that there were no statistically significant differences in rates of recurrence, death, or serious clinical events based on randomization to either family practice-led follow-up or cancer center-led follow-up. And the rates of recurrence may be a touch smaller, but not significantly so, and the other values are completely equal. They also found that quality of life, as measured by both the mental health component and the physical health component of the short form 36, and depression and anxiety were completely stable throughout the time period and did not differ at all depending on the group that the patient was referred to. So it really looks like good news that these patients, by and large, do not need to only see cancer specialists for their follow-up. What else do we know? Well, in that study, Dr. Grunfeld did not survey patients, but in a previous study of about 400 cancer survivors in Great Britain, she had a similar model where patients were randomized to family practice-led care or specialist-led care, and then surveyed patients about their experiences with their doctors and their ability to get care. And in fact, in the purple, which is the family practice-led care, patients were much more likely to report positive comments about their ability to see the physician the same day they have a problem, their ability to get good advice about their health, and the fact that their physician listens to what they have to say. She also, in that former study in Great Britain, assessed the cost of caring for cancer survivors in the family practice-led versus oncologist-led group. And as we might expect, the costs were substantially lower in the family practice-led care. Primarily, this difference was explained for by the cost of the visits to the specialist. So how do physicians feel about providing survivorship care? Well, next I'm going to present some data from the national survey of primary care physicians and oncologists in the U.S. that was conducted in a study led by researchers at the National Cancer Institute and just published over the last couple of years. So both primary care physicians in the purple and oncologists in the blue were asked if primary care physicians have the skills to care for late effects of cancer, recurrences, and psychosocial support. That question was actually asked if they were capable of doing it as well or better than oncologists. And what you see here is that primary care physicians, by and large, felt pretty comfortable that they had these skills. Medical oncologists were pretty negative that primary care physicians would have these skills. But then when you actually ask the doctors themselves about their own confidence in their knowledge about testing for recurrence, testing and assessing for physical effects of cancer treatments, and addressing psychosocial effects of cancer treatments, they were a little bit less positive, suggesting that although they feel like they could do it, they probably also feel like they need some additional training to really do it well. So can others support physicians in caring for breast cancer survivors? What about training of health promoters and community health workers? Is that an option? So next I'm just going to present a little bit of data from a study that I've worked on with Dr. Felicia, Knaul, Dra Nancy, and others in Mexico, trying to train community health workers and health promoters about breast cancer awareness. So this study involved training of health promoters and community health workers about breast cancer knowledge and awareness using a train-the-trainer type model. So Drs. Knaul and Manana developed training materials tailored directly for Mexico, and I have a few here if anyone wants to look at them afterwards. And then they trained about 169 health promoters from 2 states, Jalisco and Nuevo Leon. And that initial training involved 8 hours of in-person training, followed by 32 hours of virtual online training, and then a practicum, a practical training experience where these women went out to their communities and using a train-the-trainer approach, then they trained community health workers in the same information. These health promoters trained 2,651 community health workers using a 10-hour course, and 2,132 completed the training and completed the post-interview. So we surveyed everybody at the beginning of the training, after the training, and then a sample of people about 3 months after the training was completed. And I just have 2 slides showing the results, first for the health promoters, and then the second slide will show for the community health workers. And what you see here is that these are just 3 examples of some of the questions we asked on the survey about breast cancer knowledge. We had knowledge of risk factors, knowledge of symptoms, knowledge of family history and what that means. There were also questions about the availability of health insurance coverage for breast cancer treatments, as well as information about breast cancer treatment and diagnosis. And what we found was that, by and large, the scores on all of these items went up after the first training and then maintained at the same level 3 months later. Similarly, for the community health workers, you see that the scores were lower at the pre-training, which sort of makes sense because these women had almost no prior health care experience. Those scores went up and again stayed up after the training. So in conclusion, primary care-based models of survivorship care seem to be as effective as specialist-based models. Primary care providers may need some additional training and support, as well as systems for improved communication and coordination of care with specialists as they embark on training and caring for more cancer survivors. And finally, health promoters and auxiliary health workers may be a cost-effective supplement to primary and specialty care. So who should care for cancer survivors? Well, I think the answer is all of these people, and even the survivors themselves. And I think when Pam is going to talk to you a little bit about engaging cancer survivors in their survivorship care as well. So thank you very much.
So I just have to share that I believe that you have to live what you preach. Entonces, quien me cuida a mí en mis años de sobreviviente es la doctora que me dice Knaul. Y puedo atestar de los resultados que sí lo hacen. Así que muchísimas gracias por todo, doctora Keating.